Better sleep, sharper focus, a healthier life. It all starts with how you breathe.
Welcome to the No One Told Me, the Airway Health Connection, the Untethered Way, where better breathing meets better living. I'm Dr. Maggie Graham.
I'm Dr. Liz Turner.
We're the co-founders of Untethered Airway Health Center,
on a mission to help you breathe freely and live fully through proactive airway health.
Whether you're a dentist expanding your airway expertise,
or a family looking to sleep and breathe easier,
you're in the right place.
Each week, we'll bring you bold insights, real-world stories, and expert tips.
All to help you take control of your airway health. Because when you breathe better, you live better. Let's get started.
Well, hi, everybody. My name is Dr. Liz Turner. I am a general restorative dentist. I treat people of all ages. The cool thing about that is I'm able to see airway health through the lifespan. And I was a general restorative dentist for 8 years before I discovered the link between airway health and how it impacts not only the stability of our teeth, our dentition, our alignment, how your teeth break down or do not break down, and then chronic health. And it all starts so early. It starts in infancy because the big thing is we need as much stability of our musculature to help drive our skeletons in the right direction. And if we don't have the best possible jaw growth, we need to recognize that there are some concessions that baby made in the health department. So airway focused dentistry is really looking at the big picture of how sleep and breathing are connected to the oral cavities. And I always tell families, I'm not a sleep doctor. I don't diagnose sleep apnea. I work a lot with sleep physicians, ENTs, those that have that diagnostic capability to diagnose sleep apnea in their toolbox. So I always say I don't treat to numbers. I treat dental underdevelopment. I treat dental musculature, oral tone. And as a side effect of all of those, we see improvements in sleep quality and chronic health all the time. So from an infant standpoint, I'm sure you speak to this all the time, there's developmental norms. Like babies shouldn't be sleeping through the night. There are some primitive reflexes that they need in order to stay alive. And so we need to be respectful of those while still trying to get ourselves as much sleep as possible, but no different than adults. Babies have sleep cycles too. And so we want that sleep to be of quality too.
Absolutely. Wonderful. What kind of led you into just focusing on airway health?
Yeah, so my son was born, I've been practicing for 8 years, and he was born with oral restrictions. And when he was born with oral ties, I was told in the hospital, it's a mild tongue tie, but he's gaining weight and you don't have pain. So we'll see if it impacts his speech. And I was like, well, I don't know if I have pain because this feels fine-ish, but I also don't know what it's supposed to feel like because I have a sample size of 1. And so I tell families that a lot, when you don't have, there's so many things we can Google. I could probably figure out how to change my own oil, but every child, every dyad is individual. And when we don't have more than one within our family unit to go off, if it's really hard to know, is this actually normal? And so we tell families that all the time. There's nobody that knows their child better than, but at the same time, if they're asking questions and they're saying, I still feel like something's off, then getting a second opinion is always a good idea because you're entitled to that as a parent. So I had been practicing general dentistry for 8 years. I had been doing all aspects of that, root canals, extractions, crowns, but it was really kind of single tooth focused because that's a lot of what we learn in school. And after my son was born and had oral restrictions, he was just really uncomfortable, couldn't really figure out why. Finally, he was 5 weeks old, we had him treated, and 3 days after we had him treated with no body work, no lactation support, we didn't follow any of the steps that we encourage people to go through today. My father-in-law had a heart attack due to years of undiagnosed sleep apnea. So he had atrial fibrillation. He threw a clot. I had been concerned about it for a long time, but at the end of the day, sleep apnea puts a tremendous amount of cardiac stress on our systems. And he'd had a speech impediment since the age of 4 years old. He had significant underdevelopment of his upper jaw. So his upper jaw is inside the lower jaw. So from a breathing perspective, that has been structurally compromised. And he wasn't on a CPAP until maybe 5 or so years before that. So we'd missed at that point over 65 years of improving the quality of breathing. And then I looked at my husband, who had always been a terrible sleeper. Doctors had always only wanted to give him trazodone, and nobody had ever suggested a sleep test be run. So I run a sleep test on him. He's 6'2", he's slender, he's got severe sleep apnea. And part of it is he's hypermobile. He has the demeanor where he'll just brush some stuff off. He doesn't have the like classic sleep apnea signs and symptoms because he doesn't let it affect his life the same way, but it affects his health the same way. So then I started to put these dots together, and over the course of a month, I just like blew up everything I knew. And from there, did God knows how many hours of CE to kind of build the protocols that we've built in our own offices. Now I have courses for this that we teach because we realize like how daunting it is when you don't have an airway dentistry roadmap. But my favorite thing is babies. Like babies are just where the magic happens because they're so instinctual, they're so smart, and there's such an opportunity to really help drive their health in a favorable direction.
Amazing. Do you want to talk a little bit about airway health impacting sleep, especially in those early years?
Yeah, for sure. So it's a toughie. It's a toughie because we have so many families come in and they've got a 3.5-month-old who's been doing okay, but has been struggling under the surface for a little while, like compensating with their feeding. Now they're 3.5 months old. Supplies kind of started to dwindle a little bit because the vacuum from the oral cavity just isn't as strong as it needs to be because of the restriction. And they're at this crossroads and they're like, if it's just for breastfeeding, I really don't want to do it. If it's just to try to like make me have a little less pain, I don't want to do it. And I really don't want to put them through it. And the hard part as a provider is we have a window of opportunity where instinctually these babies are reflexively using their musculature. And that begins to transition as these reflexes get integrated. So then say the reflexes integrate, we're starting solids. They start out, they've got 100 foods that they're doing because they're doing baby-led weaning, things are going great. Well, 2 months in, they tried all these foods and now they're back down to like 3 foods because the tongue isn't mobilizing well. The lips and the cheeks are likely too tense and they're compensating. And now we've got a kid with unknown feeding aversions because they're already starting and they can't tell you they don't like a food. They're just particular with the certain texture. And that will then translate into them being 2 and 3 years old. They're now nutritionally deficient. The muscle tone also hasn't driven the growth of the jaws in as favorable of a genetic position as it can. Bone is, think about a baby with a flat spot on their head. That's compression. And because children are actively growing and they're so malleable, a little bit of compression makes a huge difference. It's the same thing for the jaws. The jaws are genetically determined, but they're really functionally dependent. So what I mean by that is if the muscles aren't creating an outward and positive pressure from the tongue, if the lips and the cheeks aren't more passive versus tense. Because if you've got a baby underusing the tongue and overusing the cheeks and the lips, those forces are inward, not outward. And that's the tough part is now we've got a kiddo who is not only now picky with textures, they now have jaws that haven't been driven in as good of a position as they could have been to support also good articulation and speech. Because if the upper jaw is high and vaulted and the tongue is low, we can't articulate things as well. We can compensate and we can learn to sound things, but we likely won't be doing it with the same fluidity. So we see a lot of patients come in who have now been seeing speech therapy for a while. And speech therapists, they argue about oral ties a lot, just like we do in medicine. And I understand that because to make a certain sound, we can often recruit other musculature to get that done. So even if you have a tongue tie, you can often articulate things the way that you need to make the sound. It doesn't mean it is the most perfect way to do it, but it's done. And so at the end of the day, speech is one of the ones, and no offense, speech people, the one I care the least about because we can figure that out and kids will hear and they'll learn and they'll adapt because they want to perform in society. Like they're not going to be nonverbal because of a tongue tie. If they're nonverbal, there's other stuff going on. So now we go into airway health. We now have underdeveloped jaws. And now we have low tongue posture. because the tongue has nowhere to live, and we're recruiting other muscles beyond the tongue. So now the tongue is down and back against the airway. We're going through a natural proliferation phase where the tonsil and adenoids are also getting bigger because they naturally get bigger as the body's learning the environment between the ages of about 2 and 6. So we already have a kid who probably had some silent reflux, had some posterior pharynx, nasal blockage. They had inflammation starting there already in infancy. And now the tonsil and adenoids are in an inflamed environment and getting bigger. So now we've got kids with small jaws, slightly or significantly enlarged tonsils and adenoids, but those tonsils and adenoids are living in a small house. So now you've got a tiny drain with a tiny blockage, but that tiny blockage is actually huge because the drain pipe's too small. So now we've got sleep-related breathing disorders. Human growth hormone is secreted in sleep. Behavioral and cognition impacts are present. And if we're not sleeping well and the brain and the body aren't healing, it's not going to grow to its full potential. And we're going to have cognitive impacts, however significant, we can't really tell you. But there is literature showing if the sleep-related breathing disorder started here, we're going to see more of the aggressive behavior. If it started here, we're going to see more of the cognition. So kind of like do your own deep dive on that. But what I tell all families is any night with a lapse of oxygen is too many nights if it's my kid. And I know all parents feel the same way. I see so frequently in like the ENT space, well, they're not bad and they're not that bad. They're not the worst I've seen when it comes to tonsil and adenoids. They're not that big. Like, I've seen worse. At what point do I want my kid to be the worst someone's ever seen before they decide to like help my child? And I kind of hate medicine and how we don't look individualized at people. So that was my rant on like infancy. And then we get into grown-ups. And then the other thing I'll add is most jaw growth is complete by the age of 6. Okay. So the upper jaw goes through a tremendous growth spurt in the first 6 years of life. And that's because the brain's developing and the musculature is pushing outward. If we miss that window, we now have the lower jaw, which is still growing slowly and then goes through a growth spurt later. It's stuck because the upper jaw wasn't big enough. So we need to accommodate for the continued growth of the lower jaw, or we're going to end up with underbite and overbite. There's all different growth patterns that we see, and we see a lot of patterns between oral ties and the type of growth someone will present with. It's kind of crazy.
It is all very crazy, but also really interesting. Because I feel like this is just not talked about a lot. It's like breastfeeding's going fine, everything's fine.
Yeah,
speech is fine, no big deal.
And totally, moms are the best they're best and their worst enemy because they'll like suffer through anything to like make their kid healthy. And sometimes it's like muscling through breastfeeding or being like, I'm just going to pivot and bottle feed. And this is the only bottle we can use. And this is what my pediatrician told me to do. But my desire as personally was to try to breastfeed for a really long time, but I lost that, but it's okay because the pediatrician said I have to do this. Like they'll compromise their own goals, even when instinctually they're like, this just doesn't feel right because they're just trying to make things easy for their kid. And like, that's good. We're our best and our worst enemies for sure.
Oh gosh. I'm just thinking about my own children. They're 7 and 4 right now, and their teeth are all nicely touching together. They don't have the little gaps there. And I was the same way before I had braces. They removed 4 of my teeth. Yeah.
It's hard. We just know so much more about growth and how it can be influenced by phased orthodontics. And what I tell families is if we really look at the details of how someone grows, we want to kind of try to ride it with like a roller coaster. We want to get that growth back on track when we need to make sure that we have the stability later on. And so frequently what we see, and this is very possible, teeth can come in crowded and an orthodontist can line them up. And they can line them up by either pushing them through the bone a little bit because there's just not quite as much of it, but they'll be straight and that's fine. That is an orthodontic approach that is accomplishing the goal. It lines up the teeth. So they're not doing the wrong thing. They're just not doing it with, in my opinion, as much detail or nuances as they can. The other thing would be to take teeth out and make more space and then bring it all back. And that's also a very valid way to do their job, line up the teeth. If we really want to think from an overall overall health standpoint, with what we understand about how jaw size influences sleep, and this is a very controversial commentary in the orthodontic world right now, is in individuals who have severe sleep apnea, who have diagnosed end stage disease, because OSA is end stage. It's not on the spectrum of sleep and breathing. It's the end of the line. But for the people in front of it, we don't have the data because we don't have a diagnosis. So for people that have obstructive sleep apnea, is the fact that does orthodontics influence their sleep apnea? It's so hard to know. Like, many of these patients, maybe they're overweight, maybe they had this type of orthodontics or that type of orthodontics. There's so many factors. So the orthodontists are saying that orthodontic treatment has no influence on airway. And just from a strictly structural perspective, that makes zero sense. If you take teeth out and make the airway smaller than it was to start, then there's going to be a restriction in the airflow. Will it lead to obstructive sleep apnea? Maybe not, because maybe you got a guy who's vegan and works out for 4 hours a day, but then you got the guy next to him who eats Doritos. Like, neither one of them really should have had that done if we could have done it another way. So it's hard. And what I would tell families is, if you're seeing signs of crowding or lack of spacing between your child's teeth, there is a structural skeletal problem that is very common and nobody's fault. In 2016, Stanford put out a paper that said that our jaws are getting smaller with each generation. There are certain controllables we have and those we don't. We can't control our genetics, and all of us are getting a little smaller in the mid-face department just because we don't have to hunt and gather our food anymore. We don't have to cook it over an open fire. We don't have to gnaw on it like a dog does. There's so many ways that we have evolved to get through life with more ease. Our lifespan is longer. You could argue we're healthier because of that. It doesn't necessarily mean that letting our jaws be small is the right choice. What other controllables are out of our control? The air quality. And there's a ton of literature coming out right now on microplastics and particulate matter. I can't control the fact that I live near downtown Denver and there's a lot of fires and there's pollution. I can control if I have an air filter in my house. The fact that I have an air filter, though, it doesn't mean that my kid is not going to have the need for palatal expansion. So you control what you can. And then the other thing we can control is palatal expansion and orthodontic realignment at a developmentally appropriate age. So the way that I describe this to families is, it's fine if you wait till the teeth come in and they come in crowded, and then the orthodontist lines them up on the plot of land that we have. So think of it like you're trying to build a mansion of all the teeth on a small plot of land. You can do it. It's just not going to be as stable, and you're not going to have as much real estate. You can't put in nice landscaping, meaning that if the teeth are really pushed up against the bony rim, we're not going to have as much gum tissue or bone support there. So the increased risk of recession is present, sensitivity is present. If we actually orthopedically expand the bones while we still have access to that while a child is still growing, we now have bought ourselves a plot of land that in time we can build our mansion on. And so it's a long game, but it's mainly so we can get what we want on all sides. We then have more stability of the bones, more space for the teeth to come in on their own versus with as much force. And finally, we have the side effect of the fact that the upper jaw is connected to the nasal passages and the lower jaw is connected to the oral airway. And the tongue, this big old piece of muscle, it lives inside there. So we have many patients come in, they say, my tongue's too big. And I say, nope, your mouth's too small. You need more space in your mouth. This is not a tongue problem. This is an oral space issue. And the hard part is skeletal movement is harder to control the older we get. So that's why I would just encourage families, if you're seeing crowding, if you're seeing lack of space between baby teeth, adult teeth are 30% larger. So they may look perfection right now, but just know, like, when they're 8 and the teeth like aren't falling out as quickly, don't let your dentist or your doctor or anybody say, oh, well, we got to wait till more teeth come in, because they're not coming in for a reason. There's no room for them to come in. You'd get an airway focused dentist, airway focused orthodontist, ask your community. We did just actually launch a provider locator. It's called airwaynetwork.com, and we're super excited about it just because we field over 100 requests a month of people being like, how do I find someone in Australia? How do I find someone in Atlanta? And the hard part is trying to vet all these practices and help facilitate and find. So now people can like go on there, they can highlight their own practices, they manage their own profile, they can schedule, do whatever you want in that way. But our whole goal is to just bring a little more ease and peace of mind to families that they're finding the right people.
Wow. Okay. So that would be your recommendation, is palate expansion?
Yeah, it's hard to say that as a blanket statement, but what we tell all families is the maxilla, the upper jaw, it's kind of like it's the problem child. It's the criminal. The lower jaw, the mandible, is kind of along for the ride. Why is that? Well, what happens in growth and development? And I look a lot at embryological development because I think it's so fascinating. The mandible has a growth center that's genetic, and it starts out as genetic. But then once the tongue musculature begins to form this coordinated and strong swallow pattern to practice coming into the world, it drives the lower jaw forward, and if it's lifting appropriate, will spread out the upper jaw. The mandible goes through a huge growth spurt in the first 2 years of life. It grows about 18 millimeters in the first 2 years of life. And then from year 2 to year 18, it grows about another 15 millimeters. So we have most of our lower jaw growth is happening in the first 2 years. So we're missing the window for treatment by improving tongue muscle strength and mobility early on. So say we miss that, what can we do? The upper jaw is on top of the lower jaw. And many times what we find is because the tongue was never lifting and expanding as well, and probably because of some nasal blockage, some reflux, maybe a little adenoid enlargement, turbinate enlargement, that jaw growth has never been as opportune as it could have been. So now the upper jaw is constricting and almost squeezing the lower jaw like a hat or a shoe that's too small. So the upper jaw needs to get out of its own way so the lower jaw can come forward. Do we do expansion on the lower? We upright teeth on the lower. And when we do that at an age appropriate time, the bone can follow. So we really are expanding it, but it's a totally different concept than what expansion on the top jaw is. Expansion on the top jaw is true skeletal sutural expansion. On the bottom jaw, we're more uprighting teeth and coordinating the bone growth and the alignment while a child's still growing. So we want to get the upper jaw kind of out of the way. So in most of these cases, palatal expansion is kind of like the root of it all, because whether it's done with the tongue, whether it's done with a myofunctional appliance, whether it's done with a fixed or removable appliance, there's many ways to do expansion. It's just in our practice, we really strive to go by as much evidence-based and controllables as we can. And we also find that when it comes to expansion, there's a lot of companies out there that are saying like, oh, you need to do it gently. And fixed expansion, it's too aggressive, it's too forceful. If you really look at the biology, it's not forceful at all, because the amount of force we're needing to generate is putting a gentle amount of pressure on these teeny tiny, really cool ligaments called sutures in the cranial bones. And we don't have to generate a lot of force at all, but it does need to be consistent and more continuous, and it needs to be symmetric and predictable. And that's one thing we run into with removable appliances. People will argue that they're gentler, that they're more biomimetic, that they're easier to clean, that they're less aggressive, they cause less discomfort. And all of that is, in my opinion, marketing, and it's misinformation. Because if you're catching a kid in the right window between the age of 4 and 8, like the ability to get expansion without true pain is 100%. You got to keep it clean, because the only pain we see from expansion, in my opinion, of the thousands of cases that we have in my practice, in my colleagues, it's because the gums get inflamed because we're not keeping the appliances as clean. And it's hard because it's the mouth, and the mouth is dirty, and kids are kids, but they shouldn't be brushing their own teeth, let alone their expander, until they're 9, because they don't have the manual dexterity. So my son, he's 8, he goes, I'm brushing my own teeth. I'm like, to hell you are, you ain't brushing those things. That's my job. So, and I don't like to fear monger them at all, but I'm like, I'm going to have to put a needle in your face and fill a cavity. And they've never had a cavity. They'll never have a cavity. If they do have a cavity, I'm not going to fill it, because I'll let someone else do that. But at some point, I'm all for like gentle parenting and like not eliciting fear in our kids. But at the same time, we do need to like really promote what oral health is. And like, you got to keep your teeth healthy. So it's hard.
I use the cavity through quite a bit, actually. flossing is a big deal with my youngest right now.
It's a pain in the butt, isn't it?
I mean, and her teeth are they're tight. Like it's
Yeah.
hard to get in there right now. And yeah, we are definitely struggling. Both of them, they're like, I'm gonna brush my own teeth. I'll start. I'm like, no, I'm finishing. You can
Yeah.
try a little
Well,
bit, but like
and can I bring up, I want to talk about just for a second about
Mhm.
the differences in pediatric and adult teeth, because
Yep.
so many parents, like, they are beating themselves up if their kid has a cavity. They're like, I'm doing everything right. Like, we eat a real food diet. We brush and floss twice a day. And if you want the honest truth, my kids get their teeth brushed once a day.
Yeah.
And it's because I control it. I control their diet, and I make sure we control all the other risk factors, especially mouth breathing, because decay comes, the number one driver of it is mouth breathing. And if you've got kids with tight spaces between their teeth who are in a natural proliferation phase of their adenoids and their tonsils, they're predisposed to mouth breathing. It's no one's fault. We would never say tape your kid's lips shut. That can be extremely dangerous in a child that we don't know has full nasal patency. I advocate for lip taping in adults all day, every day. And in a lot of our post-expansion kids who we've been able to know that they're myofunctionally trained to breathe through their nose, sure, if they lip tape, that's fine with me. But we've ensured the safety of it beforehand. But for these kids that are mouth breathing, it's not their fault. And you may be able to promote the habits during the day, but at rest, like, they've got to breathe as well as they can. And if breathing around their adenoids with a little bit of mouth breathing is what we got while we're kind of in this lead time to what do we do next? Do we do TNA? Do we meet with a functional medicine doc? Do we do expansion? Sometimes the reality of it is it's just got to happen because they've got to breathe, and that's the way they're doing it. I don't love it. I wish we could get around it. And one of the ways we do is by making more space. But pediatric teeth, if we dehydrate that oral cavity, we increase the acidity. We often will have a little bit of acid reflux that comes. There's an airway reflux that occurs. It's more of like a respiratory mist, and it happens in children too. And then we have grinding on top of it because they're trying to buffer the acid. So a lot of these kids come in with worn teeth and a high decay rate, and the parents are just flummoxed and they're sad because they've kind of gotten this talking to at the dentist, like, oh my gosh, what have you done wrong? And it's not their fault at all. The other thing is baby enamel is so thin, and it's thin for a reason. That's why it looks super bright white, because it's like this really thin, it's like an eggshell. The grown-up teeth have to eat away at the baby enamel, so it's meant to break down. It's not supposed to be as strong. So it's like this perfect storm of stuff. And then we also have teeth that are tight together, so then they've got bacteria there. At the end of the day, they're transitionary dentition. If we've got a kid who we're able to control, and there's so much cool stuff out there between SDF, which is like a different type of fluoride than the systemic one, it just arrests decay. There's peptides that we use now to arrest decay. There's a whole lot of like no drill ways we can manage these. And sometimes if you just slow it down long enough until that tooth comes out, then you're fine. It's a tough battle because I think parents get this idea because we as dentists are misinformed about what drives decay. It's all about like, oh my gosh, did your child have a goldfish cracker? And I don't love those, but they're a reality at summer camp. If I can control all the other factors, then I don't care if they have one goldfish cracker. So I hope that anybody listening to this, and if your kid has a cavity, you like are taking a deep breath and being like, oh good, I feel better now. So.
You've heard us talk about how airway health impacts everything from sleep and behavior to feeding, facial development, and overall systemic wellness. Now we've created courses to help you take the next step. Whether you're a dentist ready to transform your practice or you're an allied provider wanting to deepen your airway expertise, the Untethered Way has education designed for you. Our Foundations of Airway Dentistry course gives you the complete clinical and business framework to integrate airway-focused care into your practice. You'll learn diagnostics, treatment sequencing, case presentation, and the systems that help you build a sustainable, thriving practice while offering life-changing treatment. We've also made this course available to allied professionals, and we're blown away by how many IBCLCs, speech therapists, orofacial myofunctional therapists, dental hygienists, and even physical therapists and occupational therapists have asked for this training. We also offer advanced surgical training on frenectomy protocols across all ages, infants, children, and adults. The training is available online as well as live intensive courses with hands-on learning. These are the courses that we wish we would have had access to when we were first learning about airway dentistry. They help you condense time into helping changing lives and change the financial health of your practice. You can learn more and enroll now at theuntetheredway.com. The link is in our show notes.
Do you want to touch on breast milk and tooth decay?
Yeah, for sure. So I am a big believer that breastfeeding does not cause decay. And the hard part is breast milk in the presence of fermentable carbohydrates and mouth breathing can cause decay. So when we have kiddos, say they have a tight upper lip restriction, they've started solids, they now have fermentable carbohydrates. Because of the tight upper lip restriction, the fermentable carbohydrates are in more contact with their upper teeth, and there's not as much enzymatic or salivary flow to clear that area. These are the kids too that, because many of them are still breastfeeding, what happens is when they get decay, then the parents are blamed for breastfeeding is what caused the decay. It's really more of the mouth breathing pattern and the fermentable carbohydrates. So what I normally tell families is if you are going to breastfeed while they're going through solids, like my daughter breastfed till she was 4.5. My son was about 8 months, and it was very storied, which again is one of the reasons I was like, we're going to see how long this goes. The big thing is making sure you're cleaning and debriding, especially the surfaces of the front teeth, because that's where everything gets really dehydrated. So cleaning the teeth through natural oral hygiene. And these would be kids too, where like, just like any individual who has molars contacting, we got to try to floss them. And so when your kid's second molars come in and they're touching the first molars, you got to start getting a piece of floss through there, because then it becomes more habitual. They become more used to it. They still will fight you a little bit on it. But I tell people prioritize those tight contacts in the back for sure. If there's spacing between the front ones, they're not going to get cavities in between them as long as you're debriding them well. And then trying to reduce the mouth breathing as much as possible. So for me, I would never tell a family to stop breastfeeding because of tooth decay. I would say, what are the other things we can control here? And the number one would be trying to reduce mouth breathing. If you can't do that, you got to be even more on top of oral hygiene. And maybe it is an instance, I'm not a huge fan of fluoride for everyone. I will use fluoride in high risk situations. We've been using alternatives in our practice for the last 7 years. We will recommend fluoride treatments on individuals unless we're in a time period where there is a high risk that something else more damaging is going to happen. Because if we isolate an area and we put on a fluoride varnish once every 3 months, and then we use safer non-fluoridated alternatives on the regular, we're not going to have a systemic problem or a strong disruption of the oral microbiome. So it's really so case dependent. But that's what I tell families. Like, I don't look at fluoride as an evil. I look at fluoride as a tool that I could use to reinforce when I have to. And if I don't have to, awesome. So I would tell families to like keep going as long as you can, and good on you. So
amazing. Wonderful.
Yeah.
Do you want to talk a little bit about the difference between nasal breathing and mouth breathing and why it actually
Sure.
matters?
Yeah, and then one more thing on breastfeeding and nighttime breastfeeding. So we do have some situations where it's tough. Kids will do everything they can to breathe. Like their goal is, and who wouldn't? Like we can go without food, we can go without water, we cannot go without oxygen. There are situations, and I would say we see this often in our practice, especially with oral ties that have been dismissed more repeatedly, where a kid will night nurse all night long. And what I would tell a family is that really isn't normal feeding or normal comfort feeding. If this is a pattern that's going on all night and it's unable to be disrupted, like they can't sleep unless they're at the breast, my concern is that they're using the vacuum pressure of breastfeeding to maintain the patency of their airway. So those would be kids that I would say to the family, I really would like you to be evaluated by the ENT, because if we've got an 18-month-old who's night nursing all night long and we're able to visualize those tonsils and they've got nasal blockage, one of the best decisions a family could make, and I'm never pro surgery, I'm pro better breathing. If we have to, and we know that those tissues are going to get bigger and bigger, breastfeeding all night long isn't our strategy to keep them breathing well. They're using that as a crutch to try to survive. So I would highly encourage getting in with an ENT to just help establish a baseline of where they're at now, so that if in the coming months something more snowballs, we start to witness snoring, cold and flu season comes along, those tonsil adenoids get even bigger, we at least have somewhere for them to go more quickly than if they'd never established a consultation. And so nasal breathing versus mouth breathing. Nasal breathing, it warms, filters, and humidifies the air. And then our paranasal sinuses, when we're nasal breathing, secrete nitric oxide. Nitric oxide is the molecule, it's kind of like the Uber driver for oxygen to our cells. If we don't have nitric oxide, we're not using the oxygen that's coming in. And so people can say, I just breathe better through my mouth. Who cares? And I say, well, you're actually not getting oxygen. You're breathing, but you're not utilizing the blood gases the way that they really need to be. So there's an imbalance in CO2, O2, NO2, NO. And so really, if we can have people be obligate nasal breathers, we keep our oral cavity lubricated and safe. So we improve on the pH, the acidity, lower cavity rates, lower the microbiome threshold for periodontal disease and bad breath and all the things. So that's why in a lot of adults, especially those that have been habitually mouth breathing, like we'll lip tape and advocate for lip taping just as like one more fail-safe to try to keep people healthy, and you sleep better. Your REM sleeps better. So nasal breathing not only has huge health benefits, but think about an airplane in turbulence. When you're in an airplane and you're going through nice, clear air, everything's really smooth and nothing's disrupted. You can even fall asleep on that airplane. If you're on an airplane in turbulence, everything's bumpy, chaotic, and moving around. It's the same thing for breathing. So nasal breathing is that clear, passive air. It means that we're able to get the air in, get the air out, and there's not a vibration in the back of the throat. When we have mouth breathing or we have significant nasal blockage that causes resistance, what happens is everything begins to vibrate and shake, including the back of the throat, the soft palate, and our physical airway is collapsible. So that's where we have people that are light sleepers, have trouble falling asleep or staying asleep. They sleep for just very few hours. And we also have those that are more classic apnea. They snore frequently. They wake themselves up out of deeper phases of sleep. They'll gasp. Their partner will witness it. Women and children tend to have more adaptive sleep profiles in the sense that we won't let those bigger apnea events happen. We'll kick ourselves out of sleep sooner. So in children, for example, or even in infants, there's kind of like that startle cry. That's also the Moro reflex. But in older children, we'll see sleepwalking, sleep talking, grinding. We'll see them sleeping on their bellies with their neck in extension. It's like CPR, held tilt chin lift. They'll be all over the place. They're really hot. They wet the bed longer than developmentally normal because of the antidiuretic hormone and the connection to sleep. There's also a big connection to like the spinal galant reflex, and primitive reflex are my favorite. So we'll see kiddos that just are not performing as well behaviorally or at school, especially when they're overstimulated and exhausted. And these kids are often labeled as ADD, ADHD, ASD, because maybe they have that, but it can be made far worse by the lacks of sleep and oxygen. And so then in adults, it's the same thing. Are they snoring? Is their airway collapsing? Are they now no longer oxygenating as well, so their jaws hurt? Are they clenching a ton? Are they breaking teeth? So kind of the cascade of symptoms, it never it changes, but it's the same root cause all along. There's a study that shows bruxism. This is by my mentor, Jeff Routes. It's called the bruxism triad. So obstructive sleep apnea, teeth grinding, and acid reflux are all connected. So acid reflux is caused by OSA or sleep-related breathing disorders, which then causes grinding because we're trying to buffer the acid. And the whole cycle just keeps going. There's another study that says 85% of children that are grinding, or 85% of adults that are grinding were once children that were grinding. And so if they're grinding in childhood, they had a sleep problem then. We just didn't catch it until they were grown up and were able to say, I feel bad. I have a lot of patients in our practice who they're going through testing for ADHD. And it's hard to hear what these kids have to say because nobody actually listens to them. Like this young girl was telling the evaluators over and over again, I'm just so tired. I just feel tired. And her mom finally like overheard her say it and was like, why are we asking about ADHD when she's exhausted? So now they're looking a little deeper. They're still like doing all the things they need to because sometimes there's moving parts. You just got to keep it all going forward. So yeah, it's so fun.
Yeah. Is snoring in kids ever normal?
I would make the blanket statement it's not. It can, and this is what we see a lot. We see ENTs say they'll grow out of it. My argument is they more grow into it. So what happens is, say the adenoids are becoming enlarged, they're a year old. They've maybe struggled with a little silent or known reflux. The adenoids now are beginning to, and they've had nasal blockage from the beginning. The turbinates, when we're born, the little filters in our nose, they're born big. They're born enlarged. And then as latch improves and there's a distraction that occurs in the brain, the turbinates shrink. So for many kiddos that never latched well, what happens is the turbinates are already too big. So the turbinates are too big. They create this resistance that draws up even more acid in these undeveloped sphincters. The adenoids now get too big. Eventually the tonsils too can get enlarged. And they're never always together. But that snoring is that vibrational air pattern when there's a blockage in the tube of some size. And so for me, what I normally would tell families is they were snoring 2 years ago, but they're not now. Well, that's because the adenoids were huge at that point. They were severely enlarged and nobody caught it. And now they're moderately enlarged. So the snoring went down because they're like, it's gotten a little better. It doesn't happen every night. And so I tell people too, it doesn't have to be old man snoring. It's more like an audible breathing or purring. The other thing that we see a lot of is the position a child will put themselves in to try to reduce that and open up their airways. So for a lot of these kids, same thing as adults. Oh, I only snore when I'm on my back. And okay, that's an option. Don't sleep on your back. But if I have a developing child who's always sleeping face down with their right hand under their left chin because they're trying to hold the airway open, it's going to affect their growth. They'll often end up in a skeletal crossbite. They'll have an asymmetry in their mandible. And like, I don't really want my kid's head to be asymmetric any more than it needs to be, because none of us are perfectly symmetrical. But I also don't want it to become pathologic just because it's a risk factor for pathology in the future, especially in young females. Just because as this jaw is undergoing stress and hormonal changes, both in menses and then menopausal, we are at so much more of a risk for bone deterioration in our jaw joints. So I just tell families, especially of young girls, like we need to do everything we can to bring these young girls stability so that we can decrease their risk of bigger stuff in the future. So this is my like favorite soapbox, but it's so connected.
It is. Do you, for parents who are listening and might be a little bit worried right now, what would you want them to know?
I would want you to know that I see adults in our practice who are totally fine. They just want to be healthier. Like your child is fine. But as a parent, you want them to be fine plus 10, right? So your kid is here with us, living, breathing, talking, eating today. And they have been managed by medical care providers up to this point with no one even asking questions. You probably are the one that has been asking questions of like, how can I make my kid healthier? And I'm concerned about this. I have a podcast too. It's called No One Told Me, the Airway Health Connection, because daily people go, I've been asking that question for years and no one told me. I've been asking about the tonsils. I've been asking about the tongue tie. I've been wondering why they get so many cavities and nobody told me. And so I tell families that when we're looking at health, we're looking to make it as stable and idealized as we possibly can with the information we have in front of us. And now hopefully you have some information that validates the concerns you've seen and your kid is going to be okay. But I would say it's time to start really paying attention to what some of these signs and symptoms are. Maybe get that video of them sleeping. Maybe bring it to your next dental visit. Look on our Airway Network locator, though it's not as robust as it needs to be yet because we just launched it last week. Look on Instagram. Ask people on Facebook. Like nobody messes with the mom army. And that's the thing that we see a lot of is like there is more information now. The hard part is distilling it. So feel free to use this podcast as a guide. On my website, untetheredairwayhealthcenter.com, we have a ton of resources and literature just helping to highlight this. We have courses. So if you have a dentist who's like, hey, I've heard about this stuff. Thanks for bringing it up. I'd really like to learn more. Like send them to our courses. Moms are the driving force behind our next generations being healthier because we have more access to information and nobody can not listen to us anymore, which is good. So I still go to the same pediatrician. I've been going to him for 7 years. And every time I go, do you want to talk about it yet? And he goes, I'm just not ready. And I was like, okay, let me know when you are. But like you refer stuff out to the ENT who then refers it all back to me. Yep. And I just don't know why we can't get past our egos to be more collaborative. So it is what it is.
Well, you need a team.
Yeah.
Parents.
Yeah.
Yeah. What are some low pressure kind of supportive steps if parents are curious about their child's airway?
Everybody benefits from what's called myofunctional therapy. So if your child's over the age of 4, the chance that you can find a virtual therapist to help assist you in building the strength of the oral facial muscles is really high. Under the age of 4, it's likely going to be more speech pathologist, occupational therapist. We do have some myofunctional therapists who are extremely skilled with that age, and it can often be an SLP who also has myofunctional credentials. I would highlight Autumn Henning's locator. She's called Chrysalis Oral Facial. Her program is called TOTS, TOTS, and she has a resource. It's geared towards speech pathologists, and speech pathologists are also trained in feeding, and they're so good with kids under the age of 4 and older, but they just have a special skill set. And then those ones too have a myofunctional understanding because they've been through Autumn's course. So that's just a great way to like kind of try to find someone local. All of us that are in this space are like philanthropic. We're all trying to, like, we've all have been touched by it, and we're all like solo practitioners who are just doing the best we can with the patients in our practice. Like, not everybody's going out and running huge marketing campaigns because we're not big corporate practices. We're like small people trying to do the best for everyone. We just don't have like, $20,000 a month in marketing dollars behind us. So that's a great place to go, because what myofunctional therapy can do is it can be a test. If your child is unable to tolerate some of the myofunctional exercises because their nose is too blocked, their tongue is too tight, their jaw is too small, these people can be a great gatekeeper to help you know where to go next. Because maybe you don't have an airway focused dentist. Maybe you already saw an ENT and your concerns were brushed off. Maybe your pediatrician didn't know what you were saying. A myofunctional therapist has the knowledge to kind of, at times, be the landing place for you to know what you should do next for your kid. Because a lot of times the root cause of all this is the same, but the treatment strategy can be different based on the age and the need. So myofunctional therapy is a great space to go. And then when it comes to like finding local providers near you, I tell families like Facebook is a great resource, because you can just ask in your neighborhood, hey, I'm concerned my kid has been snoring. Does anyone have a great ENT recommendation who looks more holistically? Like, that's a good word to use, because they're either going to be really had a great experience or they're going to have had a horrific one. So you can kind of distill information that way. And then from a dental perspective, some of the good questions to ask are, what are your philosophies on orthodontics and alignment? Do you treat children under the age of 6? And are you understanding of what myofunctional therapy is? Because don't even ask about a tongue tie. Just say like, do you know what myofunctional therapy is? Because if they don't know what that is, they definitely shouldn't be treating your tongue tie. Because sometimes people say, oh yeah, my dentist said that they could treat my tongue tie, but they don't know what myofunctional therapy is. I go the other direction, because you need to understand the function before you decide to do this surgery. So hopefully that's helpful.
That was very helpful. I'm going to get you to send me all those resources, and I will tag them in the show notes below. If parents could take away one thing from this conversation, what would you want it to be?
I think keeping the best detective you can for your child's health. So through my own journey with my son, I not only discovered the connection to oral ties and breathing health, but I also recognize that there's a huge deficiency in how we look at health as a whole. Everybody has different training and different passions and different thought processes and protocols. And it's okay if you want to get a second opinion from someone else, because you might find that like, hey, between these two providers, we came up with the best possible plan, but one person does this and one person does this. So we just can't treat kids in isolation. So keep asking questions if you're concerned. Like, don't let one person's, no, I don't see anything going on, deter you from diving deeper, because there's always somebody out there who can help. It's just sometimes hard to find them.
For sure. Okay. And if parents want to learn more and where to find you,
so I have a fairly, I hope, strong Instagram presence. It's getting there. Every once in a while, I'll say something a little off label and we'll have something go a little viral. But my Instagram handle is DRLIZZZT, Dr. Liz T. And then I co-own my practice with my partner in crime. Her name's Dr. Maggie Graham. She's in Milwaukee. And we became best friends through Mom Army Instagram, because we realized as dentists, we were doing the same thing, and we'd like never met, and we were sharing all these resources. And when we finally met, we realized we were like the same person, even though very different, but our passion was the same. So we were like, why don't we just do this together? And so for us, our goal is really to help educate providers and parents. And our practice name is Untethered Airway Health Center. So Untethered Airway is how you can find us on Instagram. Our website is untetheredairwayhealthcenter.com. Again, we try to keep our resource page kind of up to date. Sometimes the links like expire, but the names of the articles are there, so you can find them yourself. They're pretty much all open access. But we are here to kind of answer any questions. You can slide into our DMs. We have a podcast too, so that's always a fun listen. But yeah, well, I appreciate you taking the time to listen and host, and it was a joy.
It was lovely chatting with you. Thank you so much.
Thanks for tuning in to the Untethered Airway podcast.
If today's episode helped you see things differently,
Please share it with someone who would benefit from hearing this. And don't forget to subscribe.
want to learn more about airway health or connect with our team?
Please visit our website, untetheredairwayhealthcenter.com, or follow us on Instagram @untetheredairway.
Until next time, bye.